and thank you for joining us for today's educational activity entitled Navigating New Waters for Advanced or Recurrent Endometrial Cancer. Today's program is supported by educational grants from AstraZeneca Pharmaceuticals and Merck and Company Incorporated. This CME activity is brought to you by Creative Educational Concepts, a jointly accredited provider of continuing education for clinicians worldwide. And you can also follow us on Twitter, where you can find announcements for future continuing educational programs, healthcare news, and more. To ask a question, do send them in, and there's a really facile system, and we want to hear from you. So please do engage, throw in questions. There's no such thing as a bad question. So that's the beauty of some of the modern technology. My name is Richard Penson, and it's my privilege to be the moderator for today's program. I'm very pleased to be joined today by an excellent panel, and I'll ask them to now introduce themselves.
Sure, thanks, Rich. I'm Kyle Devins. I'm a pathologist at Massachusetts General Hospital. I'm also an assistant professor at Harvard Medical School, and I work primarily in GYN pathology.
Hi, everybody. Good day. My name is Paula Anastasia. I am a GYN oncology advanced practice nurse of many, many decades. I have recently retired from UCLA Medical Center and currently spending my time as a freelance nurse educator and patient advocate. I want to thank Creative Education Concepts for today's program. It is my privilege to have a seat at the table with these two esteemed physicians. Before we get into the heart of today's presentation for biomarker-driven treatment for advanced and recurrent endometrial cancer, I want to review a few statistics. The most common GYN malignancy is endometrial cancer, with almost 70,000 women being diagnosed this year. It is usually diagnosed in an early stage due to warning signs of abnormal vaginal bleeding, especially in the postmenopausal setting, and therefore it's usually curable. This is the first time in 4 decades that the mortality rate for endometrial cancer has exceeded ovarian cancer. We are now seeing advanced stage endometrial cancer, and part of this is also due to rare or high-risk histologies being diagnosed. A few of the common risk factors for endometrial cancer is obesity. And we know we do have an obesity epidemic going on, of course. And we know that obesity is due to excess endogenous estrogen in adipose tissue. It's also a cardiovascular risk, which can decrease survival. Women in a postmenopausal setting who are recommended to have hormone replacement, if they are only prescribed unopposed estrogen therapy, this is a risk factor. So women who have an intact uterus need to take both estrogen and progesterone. Women with a history of breast cancer who may be on tamoxifen, this does also increase the risk. Most women will have a vaginal bleed, which will elicit evaluation by their practitioner. But it's important that we educate women of the signs and symptoms. We know genetics plays a part with Lynch syndrome, which includes not only endometrial cancer, but colorectal cancer, gastric, ovarian, pancreas, ureter, and renal, just to name a few. We know age, early menses, late menopause, and the average age that we are going to see women diagnosed are 55 to 64, although we can see it younger and older. And the biggest thing we're seeing now, unfortunately, is the delay in accessing care, whether that's due to the barriers of insurance, co-pays, or lack of just knowing what the symptoms are. Disparities in outcomes is very important as well. This is a huge concern. We know that Black women are more likely to be diagnosed in an advanced stage and therefore have a higher mortality. Access to care and trust in the medical community have been identified as barriers. We need more education. We need to educate these ladies, and the best people to do this are going to be the community internists and OBGYNs who are going to see these women much sooner than the GYN oncologists. So these are just some of the recommendations to help get the word out so that women can have better access and understanding the signs and symptoms. So as you can see, there's challenges ahead. The 5-year survival rate for advanced recurrent endometrial cancer is less than 20%. Historically, combination carboplatin and paclitaxel has been the frontline standard of care with only moderate effectiveness. Today, Dr. Penson will review the latest FDA approvals and new treatment options. But first, Dr. Devens will discuss and simplify the complex approaches to molecular profiling that aid treatment decisions. Dr. Devens, please enlighten us.
Thanks so much, Paula. That was a great lead-in. You really framed this discussion well. And I think, today I'm a pathologist and I'm speaking here. We're usually behind the scenes, but increasingly, in this modern era of targeted therapies, pathologists are really taking an active role in communication with our clinical teams to determine the best testing strategies to get patients the best care possible. And for endometrial cancer, our understanding of the genomic underpinnings of disease has come a long way in the past decades. We've come a long way from type 1 and type 2 endometrial cancers. And I'm going to start with a slide that is shown almost ubiquitously now when discussing endometrial cancer, and that is this the Cancer Genome Atlas classification of endometrial cancers, which was published in the early 2010s. And basically, many of you may be familiar with this already, but I'll briefly recap. We usually split these endometrial cancers into 4 main molecular subgroups. And if you look all the way to the right-hand side, you've got copy number high subgroup. These are mostly TP53 mutant tumors. So histologically, many of your high-grade serous carcinomas, carcinosarcomas end up in this category, as well as some high-grade endometrioid adenocarcinomas. Moving from right to left, the next group are the copy number low tumors, and these are mostly TP53 wild type tumors. Many of them are low-grade endometrioid adenocarcinomas. There are many of what were previously called your type 1 endometrioid adenocarcinomas. And moving again to the left, you have your microsatellite instability or hypermutated group of tumors. These tumors have inactivation of one of the mismatch repair genes. And this group includes patients with Lynch syndrome, which Paula mentioned earlier, who have a germline alteration to one of the MMR protein encoding genes. And they also include patients who have somatic alterations in their tumors, which may be a somatic mutation in one of the MMR proteins, or more frequently an epigenetic change, which is methylation or silencing of the MLH1 promoter. So that gene gets epigenetically silenced in about 60% of the MMR deficient tumors that we see. And then the final group all the way at the left-hand side of the screen are the POL-E mutant tumors. So this is polymerase epsilon. It's one of the DNA polymerases that we have in humans. And it has a trailing exonuclease function, which repairs single nucleotide errors that this polymerase makes as it's encoding or replicating the genome. So if you have a mutation in that exonuclease domain, you will start to accumulate numerous mutations, and these tumors are called ultramutated. If you look at the top bar, you'll see that the mutations in this particular subgroup of tumors are much higher overall than those seen in other molecular subgroups. And tumors in this group are often histologically high grade, but they perform surprisingly well overall. If we look at progression-free survival based on the molecular subgroup, you see the worst overall, the red line, is your TP53 mutant or copy number high tumors. And then the best group overall is your polymerase epsilon or ultramutated tumors. And these are a low percentage, maybe 5 to 8% of all endometrial cancers. And then with an intermediate prognosis are your mismatch repair deficient and your copy number low tumors. So one of the first things that we do in pathology when we're evaluating a new endometrial cancer and we're thinking of tests to order is we try to put it into one of these molecular subgroups. And I'm going to show you first an idealized sequence for placing these tumors in their according molecular subgroup, and then I'll show you sort of a more practical one. The first one, ideally, this is the order of testing that you would need to perform to really place tumors into their appropriate group. You would have to first sequence the POLE gene. Unfortunately, sequencing the gene is the only way to check for polymerase epsilon mutant tumors. There's no immunohistochemical stain that's a surrogate. You would have to sequence it. As you'll see later, this is the problem with this ideal sequencing algorithm. Next, you would do mismatch repair protein immunohistochemistry. Many of you may be aware that there's also the ability to test for microsatellite instability using either PCR or next generation sequencing methods. And those methods work quite well also, but they actually, compared to colon cancer, where those methods are the gold standard, in endometrial cancer, immunohistochemistry is actually slightly more sensitive for picking up these tumors. So it's a cost-effective and pretty quick strategy. You can just do mismatch repair protein IHC, and then we'll do p53 immunohistochemistry to look for the copy number high tumors. Tumors that have wild type p53, mismatch repair preserved, and have no POLE mutation would just default to this copy number low group. Now, the problem with this algorithm is that POLE sequencing is not available everywhere. It's expensive. And at this point, it doesn't alter our treatment for many of these patients. In Europe, they're de-escalating therapy in certain patients who have POLE mutant tumors. It's not yet happening in the US, although there are some trials investigating that. So a practical method that we actually use here is to just do mismatch repair protein IHC and p53 IHC. Now, the problem is this will not catch your rare POLE mutant tumors. There are some histologic features that are associated with POLE mutations that we'll mention, but they're not highly specific or sensitive for detecting them. So we're really avoiding the POLE test and taking that as a loss and just looking for these other subgroups in our current practice. Just a few quick notes. When you're looking at reports from your pathologist, nowadays, you shouldn't see positive or negative as a description for p53. We're trying to use the term mutant or wild type because there are many mutant patterns, and I don't have to go into each one. It's sort of beyond the purposes of this talk, but just know that the specific mutant pattern we see correlates with specific mutation types. So you should be looking for that mutant or wild type pattern for p53 to help put tumors in a subgroup. And then once we've gotten through all of these tests that are designed to put tumors into their molecular subgroup, there's a number of other tests that we do. I'm going to talk just quickly about HER2 testing because this is a hot topic, especially lately. I just want to briefly mention that there are different criteria for HER2 interpretation depending on tumor type. So for example, high-grade endometrial carcinomas like serous carcinomas and carcinosarcomas may have HER2 gene amplification in up to about a third of them. And in these tumors, you're really looking for overexpression of that gene to treat with trastuzumab. So to treat with trastuzumab, you need that gene amplification. So if you have a 2+ IHC, we would reflex that to in situ hybridization to look for HER2 gene amplification. And if it's positive, then patient would be eligible for treatment with that. And then there's also this new antibody drug conjugate, trastuzumab deruxtecan. These tumors use the trastuzumab antibody to direct a chemotherapeutic agent to a cell. So all you need is expression of the protein. So you don't need to do ISH for 2+ tumors. Depending on the indication and the clinical trial you're using, the patient may be eligible for therapy if 3+ or 2+ expression. The last thing, whoops, I'm going too far ahead, is I just want to summarize the studies that we do on a regular basis here at MGH. So for all new endometrial cancers, we're doing IHC for MMR proteins, and for P53, as we discussed earlier. If a tumor shows loss of MLH1 and PMS2, we're doing MLH1 promoter methylation testing. If it's positive, that's a somatic change, so patient is not at risk for germline alteration. If it's negative, and in all other combinations of MMR protein loss, the patient should be considered for genetic counseling and germline genetic testing to rule out Lynch syndrome. We also do P53, and then we're also doing ER and PR up front for a couple of reasons. One, if tumor recurs and it's ER positive, you know their patient could be treated with anti-ER therapy. And also, there are numerous ways that people are trying to separate out the copy number low subgroup to see which tumors in that group do worse. And one of them seems to be tumors that are ER negative. So those are things we're doing up front. Other testing we can do in certain situations in patients with recurrent disease or high stage disease, extrauterine disease, we're doing HER2 testing. And then you can consider other tests like next generation sequencing to try to identify a gene mutation that can be targeted. Some of those genes can be looked for with IHC surrogates like ARID1A. In very specific settings, you might consider PDL1 to look for immunotherapy candidates. MMR deficient tumors are also immunotherapy candidates, as we'll get to. And then in certain tumors, you could consider POLE sequencing as well. In that, I'm done with my component. I want to kick this over to Rich, who's going to talk about, I think, how this testing ties into the new FIGO staging. Rich?
Yes, so it's fabulous to do a program with both a really world-class nursing expert and a pathologist. And so every Wednesday morning we do tumor board, and our fellows actually present with both of these stagings. So the 2023 new FIGO staging system is really eloquent, but it's not entirely clear that we are going to stick with this. We are going to stick with molecular subtyping. So you see the M subscript over in the stage 4C group metastatic disease, and that's where it really has an impact. So for most of the clinical trials that we're going to talk about, it's advanced or recurrent endometrial cancer. But as the sort of world is shifting and we're moving immunotherapy up front earlier in the course of illness to hopefully have a greater impact on outcomes, this sort of staging is really going to change. So previously, stage 1 disease in the endometrium and how much it had penetrated the myometrium now is subdivided into much greater determinants of things. And so you can see low grade as opposed to aggressive histology. And that's really changed and upstaged patients into stage 1C with aggressive histology, which is much more appropriate in terms of both prognostically identifying risk and predictively helping us choose the right sort of treatments. Stage 2, very much the same, but lymphovascular space invasion has really taken on a new form, and that's in flux. We've gone from 5 to 3 and maybe settle out as 4 as the significant number, but some of these things are changing. And then locally advanced disease hasn't really changed very much, though the micro versus macro mets really is now important. And then, as we said, in the advanced disease, what's really new is the molecular subtyping. So if you hear people say, for example, we can't do molecular subtyping, we can't do the POLE mutations, just remember the culture is shifting, and no longer lumping endometrial cancers. We really are splitting the endometrial cancers into the new world of the molecular subtypes. And so I put an example here of early stage disease, and with a lot of work from Canada and other places, we really have moved to using vaginal brachytherapy for many patients. But I want to show you, for example, that stage 1B high-grade tumors, those are the ones that really do seem to benefit from external beam radiation therapy rather than vaginal brachytherapy. And in the NCCN guidelines, you can actually add systemic therapy with not a firm evidence base of benefit, but enough information to really sort of start to think about things that might have a, in the past, more marginal impact into more mainstream standard of care. So we're going to keep this sort of lesson about molecular classification that Dr. Devens has set up as we think about things, accessing the latest efficacy and safety data for the treatment of endometrial cancer and factoring in the updates to guidelines. So this gives us a really nice overview. This is the NCCN guidelines from earlier this year, the systemic therapy. And you can see 3 blue boxes here, the classic box, first-line therapy as we think of it, paclitaxel and carboplatin as a mainstay for all diseases, carcinosarcoma and standard treatment. And then from June, the addition of pembrolizumab for all subtypes of endometrial cancer for dostarlimab for carcinosarcoma, but this group only for deficient mismatch repair tumors. And then for HER2 new positive tumors, the addition of trastuzumab, and that both for uterine papillary serous carcinoma and carcinosarcomas. And then you see down at the bottom, these are appropriate options for certain patients in mismatch proficient tumors based on LEAP 001. Now then, lenvatinib pembrolizumab might be an option. It's not really very different from chemotherapy in outcomes. And we're going to look rather granularly at that data. But then relatively older, more infirm patients who have a mismatch repair deficient tumor might get single agent pembrolizumab for a microsatellite unstable high tumor, and that is a FDA approved option both for pembrolizumab and dostarlimab. And then you can see over on the right, in certain circumstances, there are a large number of other options beyond the immunotherapeutics for HER2 new positive tumors, as Kyle said, trastuzumab or trastuzumab deruxtecan. And then NTRK gene fusions, new agents for those as well. And so very excitingly, in June, we had the approval of both pembrolizumab, June 17th, and durvalumab, June 16th. And so to have a 1 month in which 2 new agents are approved, pembrolizumab for all endometrial advanced or recurrent cancers, irrespective of mismatch repair. And then durvalumab for patients who have deficient mismatch repair, and rather excitingly for carcinosarcoma patients as well. I actually see a question. We're going to call out questions quite readily as we go along. A little while ago, somebody asked, when should we consider HER2 testing in cases that are not serous? Kyle, do you want to just address that quickly? Because we're on that sort of therapeutic options that are listed.
Yeah, it's good timing. Yeah, I think basically tumors that could be tumors that have been shown to have a higher rate of gene amplification of HER2 are mostly serous carcinomas, but we actually have seen it in some other high-grade endometrial carcinomas, like carcinosarcomas, sometimes a high-grade endometrioid carcinoma as well. So that's for consideration of trastuzumab. And then in terms of tumors that are eligible for the combination therapy, trastuzumab, deruxtecan, those the FDA approval is for any carcinoma that has expression of the protein. So for any non-high-grade endometrial carcinoma, we're evaluating those protein expression in those tumors in the recurrent setting. And we're also performing it up front in just patients who have high stage disease with extrauterine involvement for high grade subtypes. And that goes for other GYN tumors as well. But since we're talking about endometrial carcinoma specifically, I think those are the main subgroups, are recurrent or high stage.
Right, and trastuzumab deruxtecan was approved by the FDA for 3+ tumors, but the NCCN guidelines are for 2+ or 3+ tumors, and so that sort of expands that availability as a favored option. Thank you, Kyle.
And I also, sorry, Rich, one other thing we probably should mention here is that in tumors, especially GYN tumors, it seems that expression of HER2 can be relatively variable between a tumor and a recurrent tumor. So if you're looking for a therapeutic option and a primary tumor was tested previously and was HER2 negative, the patient now recurs and there's a sample of this new tumor, it still could be worth testing for HER2 because it may end up being positive in this subclone that's recurred.
I think that's a real pearl. If you have a patient whose the clinical behavior of their tumor really changes, it is worth getting another biopsy. When there's doubt, tissue is the issue. I'm going to put up the progression-free survival curves in the deficient mismatch repair for each one of these studies. They're NRG GY0018, which was the carboplatin paclitaxel with or without pembrolizumab, with pembrolizumab maintenance. The Ruby study, which was almost an identical study, slightly smaller and used dostarlimab. And then the Duo E study, which had a third arm, which looked at the addition of the PARP inhibitor olaparib in maintenance. And we're going to talk a little bit in detail about why that's attractive. And then the ATTEND study looking at atezolizumab, and essentially in the same format. Clearly, there was no intent to compare these prospectively. You just want to get a blink your eyes perspective on this and look at the hazard ratios, 0.3, 0.28 for Ruby, 0.42, 0.36 for Attend. And so these, the take-home message for this is in the deficient mismatch repair group, these were almost identical. And so the approval of durvalumab really very exciting. You can see in this group, the deficient mismatch repair, deficient tumors, olaparib really didn't add anything to those. They get a dramatic improvement in progression-free survival by the addition of the PD-L1 immunotherapeutic durvalumab. We don't yet have the approval of atezolizumab, but it is anticipated, and it's been really excited to see our armamentarium expanded. So this is the molecular subgroup. So this is from Ruby, and we're waiting for the GY018 study. And this was a hugely impactful difference. And so as Kyle pointed out, these four groups, we're going to put them in a slightly different order, as if we were doing that sort of elite testing, the POL-E first. So the four molecular subgroups in 400 of the 494 patients of Ruby. The POL-E group, you can see the two lines are absolutely superimposed on each other. You don't need immunotherapy to do really well. You need any insult to the tumor to trigger an immune response. And then below that, quite an impressive improvement for the P53 mutant tumors, hazard ratio of 0.55. They're not as good as the deficient mismatch repair, where clearly the impact is greatest. And then there's two ways of looking at the no specific mutational profiling group. Now, in the old days of chemotherapy, a 23% improvement in delaying chemotherapy, progression-free survival, would have been something we were really excited about. We were always aiming for a hazard ratio of 0.7. 30% improvement. And you can see that improvement, that's almost 50% better than the 20% there at 2 years who haven't recurred, up to 32%. So there may be a significant impact in this group, but this group looks to benefit the least. And there's more work to tease out which patients in this group get the most benefit. One of the things we've Yes, Kyle.
I might try to riff off of you, Rich, if you don't mind. If you go back to the last slide, this might be a good time to bring up. I don't know when we should bring it up, but I imagine some listeners may have a question. For example, what happens if you have a tumor that has a POLE mutation and a P53 mutation? Or if it's MMR deficient and it has a P53 mutation. And I just wanted to quickly say that's sort of the reason why this order that you mentioned is suggested, because tumors that have a POLE mutation accumulate lots of other mutations, and it seems that they act more like POLE mutant tumors, even if they have a P53 mutation. So the P53 is often subclonal. It's thought to be secondary to the POLE. Same thing for tumors that have that are MMR deficient and have a P53 mutation. It's thought to be secondary to that mismatch repair deficiency, and they seem to act more like the MMR deficient tumors.
Kyle, there's actually another question along those sorts of lines. Can you further clarify what molecular testing you send out for newly diagnosed patients in early stage versus the advanced or recurrent tests?
Oh, yeah. Yeah, I think for early stage patients, we're not sending out for any fancy sequencing studies in most of those patients. We're just doing MMR IHC and P53 IHC to put them in their appropriate groups. We also usually add ER as well. That's probably not strictly needed, but it helps to identify that subset of tumors in that no specific molecular group that if are ER negative and may behave slightly worse. But I think, there's some talk that in low stage, high grade tumors, especially like if you were to identify POL-E mutations in that group, that may be a good group to de-escalate therapy in, but that's not, again, happening in the US at this point. That would be the only argument to sequence those tumors, but it's not something that we're doing routinely at this point.
No, we are excited about the Rainbow trial, the blue arm that will give us that evidence base to do that sort of thing, but not doing it yet, as you say. And there are certain patients, I think, answering the question, as high-grade serous cancers that have progressed beyond a polyp, where you really worry for the patient cytologically positive washings in a patient with a high-grade serous cancer, clear cell cancers where you might be hunting for a microsatellite unstable instability high source in endometriosis. There are certain subgroups where you might want to reach for one of these things, but one of the hard things about early stage disease is we are decades behind some of the developments that have happened in breast cancer. And so we have to wait for the trials to sort of move that on. We're going to talk in a little while about this deficient mismatch repair cohorts from GY018, because we're going to show the overall survival curves. One of the things that came up that was really interesting was the difference between the methylation status. So Dr. Eskandar presented this data, and what was really impressive in the data was that there wasn't much difference in the GY018. So we don't really know whether this is a better outcome for pembrolizumab because of something that is hard to measure. In the end, on that far right cohort, you can say them superimpose, and they both did really well. We typically say that methylation, which is the sort of opposite of Lynch syndrome, in which you inherit a knockout gene mutation, that doesn't confer as much sensitivity. So there was a presentation at ESMO last year by Dr. Brin, in which the response rate to neoadjuvant single agent immunotherapy in the deficient mismatch repair group was only 38%. That was in marked contrast to the huge splash data, 18 patients with rectal cancer who avoided chemoradiation therapy because they had such a fabulous response. And so we do think that endometrial cancer is relatively different to colorectal cancer in terms of having less of the Lynch syndrome patients represented. As Kyle said, 60%, 2/3 of the patients being promoter methylation to knockout mismatch repair. So we wanted to touch on one of the other studies that we now think of as a relatively old study, Keynote 775. So this is in the mismatch for repair proficient status, microsatellite stable tumors. And this was the classic old chemotherapy after you've had paclitaxel and carboplatin of doxorubicin or paclitaxel, and patients were randomized 1-to-1 against lenvatinib, pembrolizumab. When we did the phase 2, 24 milligrams, now many clinicians start at 14 milligrams, quite a tough drug, but the outcomes were really impressive. And at this year's ASCO, there was a new presentation of the overall survival. So unusually, an improvement in quality of life, progression-free survival, and in overall survival. So the extended follow-up really exciting in terms of outcomes. So this is one of our favorite options. We don't really know when you get upfront, which is now the new thing, pembrolizumab, carboplatin, paclitaxel, how this is going to change over time. But very exciting to see the use of pembrolizumab transform outcomes for patients with recurrent disease and now moved up front. DUO-E is a high impact study from last year. Shannon Weston presented this, and this was a 3-arm study asking the question really about those P53 mutant tumors. And so the study was stratified for mismatch repair, disease status, and geographical status, but they're going to, in hindsight, go back and look at homologous recombination deficiency in these groups of patients, because we haven't yet teased out the outcomes for the P53 mutant patients in which olaparib may improve outcomes. This is the progression-free and overall survival, and you can see this in the intention to treat population. So in this group, in contrast to the deficient mismatch repair, where the durvalumab was doing the lion's share of the work, you can see an improvement from placebo in gray to the, I think, teal bluish line, 38% at 18 months, up to 46% in the carboplatin, paclitaxel, durvalumab, and olaparib arm. And then too close to call differences at this point, but encouraging data to suggest this may translate into outcomes in more important outcomes for patients, benefit in terms of more important outcomes like overall survival. This is that deficient mismatch repair, 20% of the intention to treat population in DUO-A. And you can see how in this group, where sensitivity to a PD-1 immunotherapeutic is really pronounced, really no difference in those two groups, and this led to the approval of durvalumab as an option on June 14th, which is really very exciting. The proficient mismatch repair here seen that same sort of push in terms of outcome. Again, overall survival harder to call. The approval in June really very exciting. So not only pembrolizumab and dostarlimab, but now durvalumab as an option, which is fabulous. This shows that what really swung the day in terms of extending the approval. We have come so far, melanoma 2014, deficient mismatch repair tumors 2017, the tissue agnostic tumors in 2022. So now on the right, the block of deficient mismatch repair, not yet reached overall survival. So people are really having their survival extended. And then on the left, the proficient mismatch repair group, a not statistically significant, the confidence interval is 0.53 to 1.17, but the FDA isn't going to turn down an application when overall survival is nearly 20% better, a hazard ratio of 0.79, over 20% better. So that approval June 17th of last month, which is really very exciting. And as I said, the immunotherapeutic landscape is really shifting. We're moving all of these studies up front. LEAP-001, lenvatinib and pembrolizumab versus paclitaxel carboplatin. Keynote C93, pembrolizumab versus chemotherapy in patients with deficient mismatch repair disease, and then the Domenica study, exactly the same with dostarlimab. LEAP-001 is an interesting trial. So this is standard chemotherapy, frontline therapy, moving 775, the lenvatinib pembrolizumab up front. And what was interesting was that although it provided very similar outcomes, really adds an option, doesn't eclipse paclitaxel carboplatin. One of the groups that did look better was the they'd had prior adjuvant chemotherapy. And in this, all comers, and especially the proficient mismatch repair group, looked like substantially better outcomes for the lenvatinib pembrolizumab group of patients. Randomized to that, that's a 40% reduction in the hazard risk for progression-free survival. And then some of the new agents We've touched on trastuzumab deruxtecan. You can see in all but pancreatic cancer, these different groups, the non-gastric, non-breast cancer groups in Destiny Pan-Tumor 2, really fabulous outcomes. In endometrial cancer, all comers 58% overall response rate, 85% in the 3+, but 47% patients getting at least 30% shrinkage of tumor. That is just fantastic and more than twice as good as other options like single agent palliative chemotherapy. And then lastly, the Rainbow trial is really going to take these forward into earlier stage disease in these 4 groups. Red, looking at P53 abnormal, green, looking at a mismatch repair deficient treatment with the use of durvalumab. The no specific mutation profile, adding a hormone, progestin, for 2 years after chemotherapy, which has been a question we've wrestled with for a long time. How can we incorporate that effectively into treatment without bad cardiovascular outcomes? And then, if we said a few times, POLE in the blue arm, trying to de-escalate tumor with a good outcome. So some of the outstanding questions, Rainbow is going to ask about whether we can give immunotherapy alone. Other studies are going to tend to that. Immunotherapy combinations, as in melanoma, are really coming forward. And then PARP inhibitors, DUO-E, Ruby2, and Rainbow will look at the integration of PARP inhibitors, as somebody asked, earlier stage disease, some of these studies looking at that. And then predictive markers beyond mismatch repair. We haven't talked much about it. In DUO-E, it did look like in that P53 group that PD-L1 might be a predictive biomarker, but hasn't generally. It's been more than trumped by mismatch repair deficiency. And the integration of other agents, maintenance agents, ADCs, and hormonal therapy. So we are developing guidelines about this sort of very exciting time. Specific guideline and patients concordant and patient-specific therapeutic plans for patients. So I'm going to pass this on. We have some cases, and Kyle is going to describe our first case.
Sure, thanks, Rich. Yeah, if we go to the first case, I think this will be a nice way to, I mean, if people have questions too, we can answer, but hopefully get into some specifics on when to order what. So let's start with this first patient, MC. It's a 55-year-old female presenting with abnormal vaginal bleeding and pelvic pain. She's found to have a 5-centimeter deeply invasive endometrial mass on imaging and exam. And then she undergoes a hysterectomy, which shows a grade 2 endometrioid adenocarcinoma. It's 5 centimeters in size, deeply invasive, so 60% myometrial invasion. There's extensive lymphovascular space invasion, and her lymph nodes are negative, so it's uterine confined disease. So let's go to our potential answers. Now make sure you can see all of these on your screen. Make sure you're zoomed out enough to see all the options. I have to scroll down slightly, for example, to see all mine. But what additional information do you need in this case? Hormone receptor status, mismatch repair, IHC, P53 IHC, HER2 IHC, or in situ hybridization as appropriate. Next generation sequencing with POLE or more than one of the above. Please vote now. And we'll give you a little bit of time with some nice on hold music while you select an answer. Great. There's a spectrum of answers, and I think the most frequent one was more than one of the above. And I think there are many ways you could answer this question, but I think the correct answer that we are doing in practice right now is more than one of the above. We're getting, at minimum, in this patient who's presenting for the first time with uterine confined disease, so low stage, we're getting MMR IHC. So this is going to identify patients who are at risk for Lynch syndrome and identify patients whose tumors are in that mismatch repair deficient group. And we're also getting P53 IHC on all of these patients to identify tumors that are P53 mutant and maybe higher risk. And then other things that could be considered added in some scenarios are, hormone receptors, ER, PR. I don't think it would change management. We do often get these up front, though, just to identify, again, those tumors that are ER negative, that may be at slightly higher risk. And in the future, we're not doing it now, but next generation sequencing with POLI may become something that's done more frequently in these low stage tumors to identify tumors where you can really de-escalate therapy, or tumors that may be low risk despite having some histologic risk factors like that extensive LVI in this case. But as of right now, we're not doing NGS with POLI routinely. So right now, what we're doing, again, just to reiterate, MMR IHC and P53 IHC at minimum is what we would be getting in this particular patient. Rich, do you want to comment on this at all?
Yeah, more than
How does
half
this
you got
affect your
that right. So
therapy?
good job. Yeah, it was a rather sort of distorted case to make you sort of be challenged grade 2 and sort of like falling in between the sort of different typical presentations. So that same presentation, now thinking about it in a slightly different format, so essentially the same tumor, deeply invasive 5 centimeter tumor, but this time 1 of 3 lymph nodes involved at laparoscopic surgery, and this is a deficient mismatch repair tumor, microsatellite unstable high tumor. So what would you recommend? Chemotherapy, chemotherapy and radiotherapy, chemotherapy plus immunotherapy, immunotherapy alone, or radiation alone? And just bear in mind, this could be a trick question. So 63% of you say chemotherapy plus immunotherapy, and we do think of node-positive disease as high-risk early-stage disease. So the correct answer would be chemotherapy and radiotherapy. This is one of the groups where we are desperate for more trial data to move immunotherapy up front and be included as adjunctive therapy for patients with quite a good chance of being cured because they're identified at high risk because of node-positive disease. The data does not support that yet. So again, the case changes, a little bit more morphing. So the node-positive disease in a patient with deficient mismatch repair recurs at 2 years, and they've had chemotherapy, 6 cycles of carboplatin and paclitaxel. What do you recommend? Rechallenge with carboplatin, paclitaxel. They don't have too much neuropathy. Immunotherapy, single agent because they're deficient mismatch repair, carboplatin, paclitaxel, and immunotherapy, then lenvatinib, pembrolizumab, or hormonal therapy. Yes, beautiful. So 43% carboplatin, paclitaxel, and immunotherapy. That probably is the most popular answer, but really interestingly, lenvatinib pembrolizumab is considered an option for more than a third. Excuse me. And that is an interesting answer. So the 11% who said immunotherapy as an answer, that is correct. Carboplatin, paclitaxel, and immunotherapy, that is correct. Lenvatinib, pembrolizumab, that is correct on evidence. And so which one is the best is yet to be teased out. And actually, the question that was asked from somebody in the audience, are there situations where you wouldn't add immunotherapy to chemotherapy. This is a perfect example because that 11% in the immunotherapy group, I just started somebody who had a big isolated metastasis. They've just had valve treatment for heart disease, and they're in a difficult position. And so neoadjuvant immunotherapy. Now, she has Lynch syndrome with loss of, I think, MSH6, if I remember. She's likely to get a great response to immunotherapy, and starting with that in somebody who's in the 70s is an entirely appropriate first treatment. So you don't have to give chemotherapy, and the outcomes may be very good. Remember, LEAP 001, lenvatinib pembrolizumab is equivalent to chemotherapy in frontline setting, let alone 2 years out from carboplatin paclitaxel. What's lovely about this is that our options have increased. So progressive disease at 8 months on carboplatin paclitaxel pembrolizumab, which is the favored choice in the majority in the previous answer as well. And on rebiopsy, as Kyle said, HER2/neu 2+ positive. So now, what do? They're 8 months into pembrolizumab. Do you add lenvatinib? Do you switch immunotherapy? Do you use trastuzumab deruxtecan, or do you use trastuzumab with weekly paclitaxel? So people are really divided. There's if this was like a horse race, the trastuzumab deruxtecan would just win, and maybe I would add my vote to that. One of the disappointing things is the durability of benefit, but it is just fantastic to see patients do really well on this agent. There definitely can be risks of pneumonitis. You need to counsel your patients carefully about that, and with any symptoms, get a CAT scan as the most sensitive indicator of early pneumonitis. But all of these are options, adding lenvatinib. Switching immunotherapy is probably less effective. There doesn't seem to be a big difference. We have a number of clinical trials in which we add new agents, combination agents, and there may be merit to that, but just a swap from one of the agents we've talked about to another doesn't change things very much. Trastuzumab deruxtecan, if you haven't used it, is definitely a thing to try in these patients with recurrent disease who have HER2/neu 2 or 3+ tumors.
So now I'm going to be the speed talker, talking on case 5 for the same patient. We're going to change it up just a little bit. MC still has a 5-centimeter tumor, deeply invasive, greater than 60% myometrial invasion, lymphovascular space, 1 lymph node, but this time she's proficient MMR, so MSI stable. She had previously been treated with paclitaxel, carboplatin, and pembro. She recurs 7-8 months. What do you recommend now? Well, I'm supposed to read these, huh? Repeat carboplatin, immunotherapy, lenvatinib, pembro, abemaciclib, letrozole, and hormonal therapy. Sorry about that. Yay, look at you guys, 61% got the correct answer. If the patient had recurred like a year or 2 later, you could probably repeat, but given that it was less than a year, we would change it up. So lenvatinib, pembro, especially because she's MSI stable. And if you can see, the most common side effects are going to be hypertension, diarrhea, hypothyroidism. As a single agent, we know how to manage this because we're so used to VEGF, vascular endothelial growth factor with BEV, that we can manage those. I'm going to tell you, when you're using combination, though, it's a little bit tricky, but I just want to bring this up, especially to those of you who have not had a lot of experience with clinical trials and the grading system. It's so important that we communicate with the healthcare team. And that includes the physicians, the pharmacists, infusion nurses, exam nurses, NPs, PAs, and documenting everything. But we have to be speaking the same languages. So grading system is the same language. But if you're not familiar with it, how do you speak the same language? So like I like to say, there's an app for that. So I really have my nurses use this. It's really helpful. And you can search a side effect such as diarrhea, nausea, hypertension, and it will describe the grade for you based on the number of events, lab events, or blood pressure. So I just wanted to plug that in there. Now going to Pembro, we know, like I said, how to manage hypertension, diarrhea. NPs and PAs are great at this. Multidisciplinary team is very important. Those of you that have used immunotherapy as a single agent, you're very familiar with the itises, pruritus, dermatitis, colitis, pneumonitis. You know how to manage these, but it gets a little bit more tricky when we're using dual agents and what's the cause. So what do we do and how do you dose reduce and when do you hold? Well, we know if we're giving Pembro every 3 weeks, we're not going to hold it because it's already been given. What's really easy with lenvatinib is short acting and you can stop it. Very commonly, these patients on this regimen will have diarrhea. And because it's short acting, you just fold it and it usually clears up in just a day or two. So you know it's related to the lenvatinib and you can dose reduce. As Dr. Penson had mentioned, FDA approved 20 milligrams based on patients' prior experience with chemotherapy, comorbidities. A lot of us are starting patients at a lower dose, either 14 milligrams or 18 milligrams. But once again, that's 2 different doses. So once again, you have to deal with finances and patient copays and insurance and all of that. But dose reducing can really make a difference in clinical benefit and how the patient tolerates it. Now, if it doesn't clear up, I'm talking about the diarrhea here. If the diarrhea does not clear up, then we want to think that this is probably due to the immunotherapy, and we will get a CT and you can look for inflammation there. When I was talking about grading system, this is one of the common Q&A that I often get from my nurses, like with diarrhea, if you're using combination lenvatinib and Pembro, how do you know what the cause is? And like I said, you stop the oral medication. And usually if it's due to the lenvatinib, it'll clear up or lessen pretty quickly. If it doesn't, then we are going to think infection or colitis. The other thing is education to your patient is key. And patients are very nervous about reporting side effects because they're afraid you're going to take them off therapy. If you're giving something with an oral agent, you're not going to see this patient for about 3 weeks when they come in for their next cycle of Pembro. So pre-treatment education is key. Talk to your patients, the risk factors and how common diarrhea may be, hydration, over-the-counter anti-diarrhea medications, this type of thing. But have the patient check in with you, have a designated nurse or point person. So when they're starting this, at least you have an idea. So that's really important. Let the patient know up front that there's a possibility that we could lower the dose or we could stop the medication for a short time to get you through the treatment, but that doesn't mean that you're not going to have a good outcome. So if patients are prepared that this could potentially happen, they're more likely to communicate with you with that honesty, which is so important in managing these patients and that shared decision-making. Colitis, as I mentioned, we use steroids usually when it's a grade 2. And I often joke that it's really important that you know what the patient's baseline symptoms are. So again, grade 2 diarrhea can be greater than 4 to 6 over baseline. So when you're working with a multidisciplinary team and the infusion nurse or the resident said, oh, the patient just said they have diarrhea, should we dose reduce? Well, what's the definition of diarrhea? Well, they just said they had diarrhea. Well, what's their baseline and how many loose stools did they have a day? If they had just 1 loose stool, which is the patient's definition of diarrhea, that in my book does not constitute doing anything but over-the-counter medications, anti-diarrhea medications, and hydration. So again, just keeping that in mind. Hypertension, once again, we know that the Society of Cardiovascular now has changed the parameters of what hypertension is. So know what the threshold is in your clinic. 140 over 80, you may want to lower that threshold now. Patients over 120 over 80, you might want to start at a hypertensive medication. Once again, what's the patient's baseline? Do they already have hypertension? If they do, partner with their internist or their cardiovascular specialist. Once again, NPs and PA are great at managing this. For patients that don't have any hypertension, oftentimes we will write a script, something like amlodipine, send it home with the patient, have the patient check their blood pressure daily. I know Dr. Penson's group is magnificent in providing blood pressure cuffs for their patients. We don't have that luxury. So sometimes patients, if there are barriers to care, once again, we'll have them go to a local drugstore like CVS or Walmart and check their blood pressure on a daily basis, keep a record of it, and then report back to me. And then give them the parameters when to call so that we intervene. Hypothyroidism, once again, we can partner with endocrinologists. You can do it yourself, PCP. Usually we're going to intervene when the TSH is greater than 10. And once again, you the chemotherapy orders usually have the labs built in. If the patient does have hypothyroidism, then you may want to order the thyroid function test more frequently than you were doing. It might be every other cycle. Now you might want to do it sooner than that. So just paying attention to that personalized care for your patient. So I know I'm speaking very quickly, but I just want to throw this in, switching off of lenvatinib and Pembro. Now that we're starting to use a little bit more of the, oh gosh, I have to say this again, the TDX, trastuzumab, thank you. Oh my gosh, pronunciation. We know that interstitial lung disease and pneumonitis is not that common, but it can be life-threatening. We know that in all the studies and you know, if you look in the PI and they have all the diseases and all the clinical trials, less than 1% had a grade 3 or 4, and less than 10% had grade 1 or 2. But it's not 0. So it's something really to hone in when you're doing education with your patient and the caregiver. And again, inform patients that these side effects can be subtle. So you think about something like shortness of breath with exertion, but no change in ADLs. Patient may not report that, but that would be a grade 1. And we would definitely want to do a high-res CT scan of the chest to look for any inflammation going on there. So really important. We're going to delay the dose. This is given every 3 weeks. You're going to delay the dose until recovery to a grade 0. If it resolves within 28, 30 days, then you dose reduce and continue it. But at a grade 2, you're going to permanently discontinue. This is when we, again, partner with a multidisciplinary team, especially pulmonologists. They can do further workup, but just really knowing the interstitial lung disease and pneumonitis, not common, but not to be ignored, and really educate the patient. So again, real quickly, education to the patient, patient-centered, shared decision-making, explain treatment options to the patient, especially for the patient with advanced or recurrent. Historically, it was chemotherapy only. Now we have immunotherapy added to it to prolong survival. But again, explaining, you know, how it's given, what the side effects are, pros and cons of that, patient lifestyle, are there clinical trial options? What are the patient values? What are the patient's goals? And all patients will have different answers for you. But really listening to the patient, talking to the caregiver, how accountable is the patient in calling you if there is a problem, talking to the patient about long-term, late onset, side effects, that sort of thing, and discussing with a multidisciplinary team. We like to involve the palliative care team, and that doesn't mean end of life, that means symptom management, but also looking at all of the other things, social service, finances, dietitian, pharmacists, infusion nurses, all of the people that make up this team. We can't forget our pathologists, of course, that are helping us make these biomarker targeted decisions. Inform the patient and the caregiver whom to call and when to call, and remind them that our goal is for you to live well despite having therapy. But if you are afraid to, quote unquote, bother me, and you end up in the emergency room, then, we're defeating the purpose of this. So I remind patients, they're never a bother. Please, please, please call and let them know what some of the emergencies are they should be calling us for. Addressing potential healthcare disparities, cannot emphasize this enough. Talking to the patients about their values and goals. Emphasize that we'll always be honest with them. I ask patients, my doctor asks them, how much do they want to know? Some patients are just like, tell me what I need to know today, the side effects. I don't want to know if I'm going to die. I don't want to know prognosis. Don't give me statistics. We have other patients and they come in with pages and pages, every clinical trial, every, possible treatment, and everybody's different. And that's okay. If you can partner a patient with another patient, the patient's been on a clinical trial, introduce them so that they know that, clinical trials might be an option. Support groups, really important. Exercise programs, all sorts of things to, again, help the patient live better, live well. Financial, again, patients that are on Medicare that are taking oral agents, patients that are getting a weekly treatment and they have to pay for parking. At our clinic, parking was $20 a day. I had a patient that finally said, Paula, can you please give me a handicap sticker, which of course I was happy to do. She goes, I can't afford the $20 every week. And then if you guys want me to come in and do labs, another additional day, I can't do that. Patients are taking time off from work, daycare, all of those things that, we know intellectually, but we forget on a day-to-day basis how it interferes their life.
Just briefly in summarizing, our guideline-directed molecular profiling is just transformed care for patients. Using the multidisciplinary team is essential to getting them the best outcomes. The latest evidence base is really very exciting. And I want to say thank you to Paula representing nursing, so essential, and Kyle to the pathologist. If both of you can make a comment at the end, we are running slightly over time. To receive credit for this activity, you complete a post-test evaluation under the request credit tab of this program. And I want to personally thank you for joining us today. Be safe and take care. Last thoughts, Kyle?
No, I think we covered everything. It's a nice comprehensive discussion. Yeah, thanks for having us. Thanks for the questions. Thanks for participating, and thanks to you and Paula for a great discussion.
And Paula, take us home with a final comment.
My final comment is to always leave the patients with hope. If the treatment that they're currently on isn't providing the clinical benefit that we all want, there's a plan B. And I think that's really important for patients to know that this is not the last stop effort. And with the clinical trials you guys are doing, there's always a plan B. So keep up the good work.
Yeah. Patients at the center and transforming their future with new waters for advanced or recurrent endometrial cancer.